Today we're going to begin the study of the reproductive system. We're going to focus today entirely on the male reproductive system and its function in the production, storage, and delivery of spermatozoa, and the production, storage, and release of the male sex hormones. The minor role as the last portion of the excretory system for urine we'll touch on a little bit, but primarily we're going to be interested in the anatomy and the physiology of reproduction. The first thing we really ought to look at is the embryology and the development of this system, because there are such marked similarities and what are known as analogs between both the male and the female. And at a certain point in the development, you really can't tell them apart. Let's look at the first slide. This shows the undifferentiated stage, which is about 5 weeks of gestation. Here we have the entire area called the genital tubercle, which is very, very small, and this is, again, a schematic representation. The area represented in this orange is called the glans area, which will change. Then we have this area called the urethral folds and a groove up the middle. And finally, something called labio-scrotal swelling on both sides. Again, because this is the same in both the male and the female. The very bottom here is what's going to become the perineum, which is the space between the anus and the base of the sexual organs, and the anus will form back here. We're looking almost straight on and a little bit upward. If we move on to the 10-week embryo, we start to see some differentiation taking place. This area is going to become the glans penis, or the head of the penis, while the exact same analog in the female will eventually become the clitoris. Then if we look down the middle, we get an elongation of the urethral folds. Remember, the urethra is the part coming out from the bladder to the outside, with a slit down the middle. And then finally a connection between the perineum and the anus, which has evolved from the same structures on both sides. In the female, the urethral folds here are going to be eventually kept open, and we're starting to get folds in what will in the female become the labia majora and minora of what is known as the vulva. Finally, just before birth, in the male development, we have complete differentiation. We have the glans penis and the external opening of the urethra. Now look what's happened down here. Along the penile shaft, those two folds above have closed completely over. We have a ridge of skin that connects this whole development of the genitalia back through the perineum and continues around the anus. There are cases where this skin doesn't close over entirely. If we look at the fold here, we would like this urethra, which connects with the bladder, to be closed. There's a condition called hypospadias. And when this fails to close in the male, instead of urine coming out of the tip of the penis, out the end of the glans where it should, it actually leaks from this point. It's just a failure of closure of that analog, and that's surgically corrected right after birth. In fact, this is something that is a matter of correcting at just the right time when the baby is born, so that we have enough tissue to work with to close these cases of hypospadias. If we look at the female at the same time, the large area that was the glans in the male has now become rather small, becomes the clitoris, and then we have the external labia here and the internal labia here, or the majora and minora, and this part remains open as the vaginal opening. And then we have the same connection through the perineum with the anus. So this area in the middle is called the perineum, or the perineal body. Now that's the development of the external organs of sexual reproduction. We have a similar analog if we look at the internal organs of sexual reproduction. We look at the top here, we have the undifferentiated stage. Going from the top here, we have what are called the gonads. They're elongated, and they're bilateral. There's one on each side. There's something called a paramesonephric duct, and also called a Mullerian duct. And then we have another one called a Wolffian duct or a mesonephric duct. These are very, very undifferentiated. You cannot tell at this point whether you have a male or a female. And then we have something called the urogenital sinus. This is about somewhere between 5 to 10 weeks. We get a shift at about this point, and we start seeing on the male side the development of the testes, something called the epididymis, and then the early development of the Wolffian duct, which is going to become the spermatocord. Little outpouchings on this side are going to become the seminal vesicles, which we'll see in their mature stage, and finally the prostate developing at the base. Now, this duct, which we saw up here as the Mullerian duct, is going to actually degenerate in the male. On the female side, that side is going to continue to develop. The Wolffian, which is the male analog, is going to degenerate, and the duct here is going to become the fallopian tube, which will lead into the two fused Mullerian ducts to become the uterus later. And of course, the gonads will develop as the ova on both sides, or the ovaries. Finally, when we get to just before birth, the male's testes are going to descend, physically descend, down through the pelvis and out into the scrotum through what's called the inguinal canal. Prostate will enlarge, and we'll look at that in more detail later, and this will be the final development of the male just at the time of birth. The female will keep her organs inside the pelvis. They will not descend through the canal, but they will come down on either side of the pelvis, and we'll have a uterus markedly enlarged here with its attachment to the vagina, and then this remnant of the mesonephric duct will be a piece of peritoneum between the fallopian tubes and the ovaries. So what we have here is the gradual differentiation between the two sexes occurring very late, really, in embryonic development. Only just before birth are they really very different. Occasionally, there are malfunctions of this system, usually chromosomal abnormalities, which we'll talk about later, and you can get some vagueness in the two sides. You can get both female and male attributes in certain children. This is called hermaphrodism, or the child is called a hermaphrodite, coming from Hermes and Aphrodites, the male and female god and goddesses. And these children have analogs of both. They may have a not completely formed penis and a not completely formed vagina. They may have more or less of one of the other sex's organs. And usually these patients, especially in extreme cases, are sterile, so they can't reproduce anyway. But most of them have definitely abnormal sexual function, even though they have both organs. Neither side develops completely. They're rather unusual today. We don't see this very often, but we do have very carefully mapped diagrams of exactly how it happens depending on the chromosomal abnormality. Let's look now at the gross anatomy of the male reproductive system and work our way through to the physiology. If you look at the next slide, we have a sagittal section. This patient has been cut down the middle by the artist, but the artist has cheated a little bit. If you look down here, we have the section going straight through the anus and straight through the middle of the penis, which would be a perfect mid-sagittal section. But then you wouldn't see the testicle normally because there's one on each side, and certainly you wouldn't see the cord going up. And so this artist has given us a three-dimensional view for clarity. The right side has been taken away, and we're theoretically looking at the left side in what is partially a mid-sagittal section. Let's go and look at this from the outside to the inside. Here we have the glands on section and the urethra going all the way up through and taking a turn and reaching the bladder and the prostate. It goes through the center of the prostate, right above the perineum. Perineum being halfway between the rectum and the base of the penis. This picture also shows the foreskin in place here, which is just redundant skin going back to the edge of the glands. And here we have the scrotum. Scrotum, the word for scrotum merely means sac or bag. And this scrotum has several layers. It has the superficial fascia, which is a thickening under the skin, and it has smooth muscle in it that can contract and wrinkle and pull the scrotum up nearer the body for warmth. The reason this evolved is, for some unknown reason, the production of sperm happens to occur more at a temperature that is lower than body temperature by about 3 Fahrenheit degrees. That's the optimal temperature for the production of sperm. So the body has placed, and evolution has placed, the testicles outside the body where they may be cooled. But in very cold weather or cold conditions, such as water, in a lake, for example, the muscles can contract and bring the testes closer to the body for warmth. This can be a two-edged sword because body temperature is not good for sperm production, can cause abnormal sperm production, and can even lead to testicular cancers. There are cases when the testes fail to descend. Instead of coming from the abdomen and migrating through the inguinal canal and to the outside, we have something called cryptorchidism. The testicle is referred to as the orchid. Cryptorchidism is the hidden orchid, and sometimes these testicles are somewhere between the inguinal canal near the pubic bone and all the way inside the body. Now, as I said, this can lead to sterility. It can lead to cancer, so we like to bring these testicles down as early as possible. And the way we do this is either using a chemical, which is called a human chorionic gonadotrophin, which is given to the child, and this stimulates the further descent of the testes in some cases, or we can bring them down surgically if that doesn't work. So it's always best to do it by medication if you can, but this can be done by an operation. If the testicle is going to be brought down early in life, we like to do this for psychologic reasons very early in the child's life, or waiting until they're closer to puberty, because psychologically surgery on anywhere on the penis or testicles is perceived by the child as a really vicious attack and can have very disturbing effects on their psyche. So we tend to do our timing of surgery in this case based more on emotional, psychological issues than actually the physical issues. Spermatogenesis is the word referring to the production of the spermatozoa or the sperm cells, and that begins sometime around the age of puberty. If we look at the next slide, here's the anatomy of the testicle and the spermatic cord. This is where the cord has migrated down through the inguinal canal from a retroperitoneal position. It is outside the peritoneal cavity. We'll see that the female organs are inside the peritoneal cavity. And as you can see here, we have a muscle, a smooth muscle on the outside called the cremaster. It's seen in its entirety here. This is the muscle that can contract and pull the testicle closer to the body for warmth. It is an involuntary muscle. Some people have voluntary control and can actually raise the testicle at their own will. Inside the cord, we have a big plexus of veins here, and known as the pampiniform plexus, and then we have a single small artery coming down to supply the testicle. These veins can be a problem because they can develop swelling or become varicose veins, and sometimes the pressure they exert can suppress sperm production and make the man sterile or infertile, and this can be treated surgically. Those varicose veins can be removed. Now, when we look at what's going on more deeply in the system, this is a cutaway or a sagittal section of a single testicle. The other term is testis. Here's the blood vessels, the pampiniform plexus and the spermatic cord. We have several layers here, and if you look carefully, it's very segmented. Outside, on the very edge, we have a thickened area called the tunica vaginalis and the tunica albuginea, which means white. These are very tough, fibrous protection for the testicle. They have great tensile strength and they provide protection. And the testicle itself is divided into lobules and tubules. And what happens is sperm production begins down here in these areas and eventually moves into this network called the rete testes and finally ends up in an efferent duct, efferent being away, and then moves out through this coiled duct here until we get the beginning of what is called the epididymis. If you look at this plane, it looks like an appendage attached to the testicle, which it is. It's called the epididymis, and it leads away and up through something called the vas deferens or the ductus deferens. In the spermatic cord, this is the place where we do vasectomy, when one of the most safe and effective methods of birth control is to remove a section of the vas. It's very accessible right under the skin. It actually feels different than the veins or the arteries. The urologist or the surgeon can feel the vas. It almost feels like a strand of spaghetti, something very hard within the soft vessels. And through a tiny incision under local anesthesia, this can be brought out. It can be cut, a section removed, the ends tied, and that will stop the migration of any sperm that are left inside the testis. Now, spermatogenesis is a very complex process, and I want to go through it in detail because it explains a lot of the genetics that we have going on. Remember, all of it is taking place here. The birth of the sperm, which goes on all through mature life, is a continuing process, but the maturation occurs primarily right here in the testis. If we look at the next slide, this is the outside, and then we have some smooth muscle here. Here's a capillary, and we have a bunch of cells here that you might want to look at first. This is called an interstitial endocrinocyte. By now, certainly you know that means an endocrine hormone is being made here in this cell or site, and it's called the Leydig cell, and it produces testosterone. This is where the male hormone that we've seen before that looks very much like the female hormone estrogen, has a slight difference in its radicals, is produced to nurture and encourage the production of the spermatic cells. We have something here called a basement membrane. I just want to let you see it because we're going to talk about it in our last lecture on cancer, but most tissues have a basement membrane made of collagen, a protein layer that's tough and separates it from other areas in the tissue. Now what happens first is we have the spermatogenic cells. These are immature cells, also called spermatogonium or stem cells. And I'm going to bring you to another slide to show you the actual genetics of the DNA. This is the stem cell from which all the other cells arise. And these mature literally down here in the basal layer, right next to the basement membrane, and they do actually migrate up as they get more matured. This spermatogonium has what we call 2N. N is the number of chromosomes. And when you have the chromosomes of both your mother and your father in a single cell, which every other cell in your body has, except the germ cells, then that's called 2N. N is from the mother, N is from the father, and that number is 2N in these cells because these are just like the rest of your body's cells. Then the next cell, called the spermatogonia, start to make their way up. And we get something here called this primary spermatocyte. And notice they have little bridges between them. So information can be shared as well as material can be shared. It is still 2N. And as it matures, we then undergo more divisions, and we have something called a secondary spermatocyte, and something has happened between here and here. And I'll go into what that is, but basically now we only have the number of chromosomes that would be in one or the other parent's germ cells. Finally, maturation takes place, and the cytoplasmic bridge is not broken until we get back up into what are called the spermatotids. Here's an early one, just developing a little tail, and then we get to late ones, and finally we get to the mature sperm cell, which is also called a spermatozoon. And it has the single number, or the haploid half number of total chromosomes. Every other cell in your body has diploid number, meaning all the chromosomes from mother and father. This one has the haploid number, as does the ovum that comes out of an egg. They do literally sit there tethered like a boat and a dog with their head buried in the tissue. This is the lumen, and the tails are sitting here flailing away in the lumen of the duct that's going to lead them away when they are released and matured from the testicle. This whole process takes about 2 to 3 months from the time that one of these stem cells develops and matures and gets up here to be a fully matured sperm cell. We have something else here called a Sertoli cell or a sustentacular cell, which is also providing nourishment through the tissues for the spermatogonia. Now, what happens up here that we have to look at is we're going to digress a minute and look at chromosomes. This is a chart of human chromosomes that have been taken out of a cell and using very special separation techniques and microdissection have been lined up in pairs from the biggest to the smallest. They can be matched manually by the way they look. If you notice, chromosomes have 2 sets of arms. They have what are called the P arms, or the petite, the small arms, and then they have the long arms down here. And there are 23 pairs. When I was in high school, we thought there were 24 pairs because the first investigators actually counted the same chromosome twice. And nobody challenged it, and this went on. It was in textbooks, and I grew up thinking there was a total of 48 chromosomes and not 46 from the 23 pairs. If you'll notice, the ones that are different is the number 23, which has an X and a Y. These are the sex chromosomes. There's virtually no information on the Y chromosome, but the X chromosome and the Y are called the sex chromosomes. We'll talk about those again later. Of other interest here is chromosome 21. When there are 3 of these by a genetic mistake, you have something called trisomy 21, which we know as Down syndrome. It used to be called Mongolism. It's a combination of physical and mental retardation, very, very common, and common in aged eggs and aging sperm as well. So the older parents tend to have children with Down syndrome. These chromosomes this is the diploid number. We have 2 of each. So what happens when we go in both the female and male reproductive system? This slide shows the progress and the divisions that take place. It's upside down relative to the slide I showed you. So here's the outside, the basement membrane of the seminiferous tubules. This is the superficial side. We have daughter cells. Here is our basic stem cell with the 2N number, the 46 chromosomes. It's a spermatogonium, and it will divide with something called mitosis, which means the whole pair of chromosomes will divide and will have the complete number still. There's no loss of chromosomal material. One of those will become a daughter cell, so we keep our number of stem cells, and the other one will undergo differentiation to be pushed away from the basement membrane and differentiate into that primary spermatocyte, which we saw before. It still has 2N. DNA replication and crossing over occurs here. If we did not have crossing over is when the arms of the chromosome exchange DNA. I give you part of yours and you take part of mine, and now we have a new strand and combination of traits. If that didn't happen, we would tend to be exactly like our parents. There'd be no genetic shuffling of traits and recombining. Nature found this to be, or evolution found this to be, very beneficial if we could shuffle the deck every now and then. So instead of having a repeat of every generation when we get the similar parents, in every division here that occurs between the primary spermatocyte, before we get into the secondary spermatocyte, and the same thing occurring in the eggs, the cards are shuffled. And the way they're shuffled is by random crossing over and exchange of similar chromosomes. So number 21 would exchange with 21. They wouldn't exchange with another chromosome. So they would be exchanging the same locations of their genes, but they might have different attributes. One might have brown eye, blue eye, different things of all our characteristics would be constantly shuffled, millions and millions of times. So we get this this array of different traits, and then evolution is going to work on those different traits, see which ones are better, so we have selection of the fittest. At this point, a type of division which is no longer called mitosis, but rather meiosis, is reduction division. And in reduction division, you only carry away the one of each of the pairs of chromosomes. So now each of these guys has only half the complement. They each have 1 through 23, a single copy of each in normal circumstances. Finally, they become the spermatotids, each with a single number, and finally we get the sperm cell. Now, the germ cells in both the male and female are carrying half the number, so when they join again, we'll be back to the normal number. We don't want to have more than the normal number of chromosome or DNA material. It always leads to errors. Nothing good comes of it. We do have cases where there's 3 X chromosomes and 1 Y or no Y. Some of these are called super females, but they're really not. They are actually usually have great many problems in all their systems. So reshuffling is important for natural selection, also maintaining the diploid number in the adult and the haploid or half number in the germ cells, which are the only cells that have that, is very important in nature, and keeping it that way so that we don't have any bad traits coming through because of too much or too little DNA. What happens now is, as we proceed from the gonad or the testicle upward, the sperm cells start making their way up the epididymis. Now, each sperm cell has a very characteristic look. Here's a great magnification of a sperm cell. It has a very distinct pointed head, the point of which is going to try to penetrate the outer coating of the egg. It has a nucleus with all the DNA material in it. That's where it's carried. Half the number, but all that the sperm has. And it has a mid-piece that is full of mitochondria, which, as you may recall, was the energy production part of the cell. All our cells have mitochondria. For its size, the sperm has a huge amount. And then it has a very well-developed tail or flagellum, and this tail actively whips back and forth, literally like a whip, and propels the sperm always in an upward direction, always up toward the ejaculatory part of the reproductive system. Motility increases as the sperm matures, and in the meantime, the smooth muscle of the epididymis is pushing all the sperm upwards. This is not semen. These are just sperm cells. It's just cellular material and a little bit of fluid that's driving it upwards. Now, when they get to the upper portions of the vas deferens or the ductus deferens, It enters the inguinal canal and eventually gets into the transverses in a retroperitoneal manner, goes up over the pubic bone, across the inguinal canal, and staying outside the peritoneum on both sides, curls down behind what is shown here, the ureter, and enters something called the seminal vesicles and the ampulla here. An ampulla is a big opening. What happens at this point is that they come to rest. There's a combination of organs here that we can look at from another view. This is the back of the bladder. Remember now we're extraperitoneal, so the peritoneum would be lying across here. The pubic bone would be in front. This is the patient's right side and left side, and this would all be covered with peritoneum. And then what would be between us and this would be the rectum if the patient were intact. That's all been taken away. If you look, this is a distended urinary bladder. Here are the ureters coming down from behind, and we see them penetrating the bladder down low. The vas deferens, or the ductus deferens, runs behind it and enters something called the ampulla of the vas deferens, and it is next to the seminal vesicle. At this point, the sperm come to rest, and they stay there being nourished by their secretions, and they are also going to get ready to go into this ejaculatory duct. Inside the seminal vesicles, there's a fluid that nurtures and protects the sperm cells. First of all, it is a basic solution with a good pH buffer because the female vagina is acid. It's acid, so it can protect the vagina and the cervix from infection, from bacteria, fungus, and so forth. That acid environment, just like the stomach, is protective. However, it'll protect them from the sperm, which we don't want. So the sperm gets a coating from the seminal vesicles, right here, of a fluid that is now called semen, and it contains neutralizing material as well as some mucus to help protect it. It's a little spacesuit to protect it from literal physical trauma. It also has some material called prostaglandins, which are chemicals that increase sperm motility, makes them wiggle their tails a little faster. And this lies at the base of the bladder, right next to the prostate. What will happen during ejaculation is that the seminal vesicle fluid will mix with the sperm just before it comes out through the openings into the urethra right in the middle of the prostate. Now, this little gland, which is about the size of a walnut, acts and is set up almost like a hand-warming muff. Here's the urethra going through the middle, and this completely surrounds the base of the bladder and the exit through the urethra. The ejaculatory ducts enter right within the prostate gland and aids in, again, longevity and motility of the sperm. There are something called Cowper's glands, which lie just below the prostate. They secrete a fluid also which neutralizes the acid in the environment of the urethra and is there in the male to deter bacterial growth, but which we want to neutralize before ejaculation. And then there's more mucus secretion, which buffers the sperm against injury. The sperm are going to be fired out at high velocity, and they're going to slam into the cervix, which is actually quite firm. And that can cause a literal physical damage to the sperm, so they get this little coating of mucus around them to protect them. The sperm actually have a rough life. They don't have much of a chance of survival, which is why we literally have 1 million or more sperm in every ejaculate, because there's so little chance of any one of them surviving. They also help themselves. Each of the sperm has a little bit of material that helps the others. There are enzymes that are required for the sperm to break down the protection on the outside of the egg. No single sperm has enough to get through. So all of them together pool this fluid. All of them try to get in. Only one sperm is going to, because the opening will be sealed the instant one sperm penetrates. We don't want any more DNA in there, but they will be pooling their material to help that penetration. When you see the number of sperm required, the chemical environment, it seems like a miracle that anybody ever gets pregnant. On the other hand, it was designed this way with great big backup and redundancy, and the numbers of sperm are very important. In cases of infertility, one of the first things we look at is the sperm count, because that really can tell us a lot as to whether that is the problem. Let's move on now, and we'll look at the penis again from this sagittal section. The penis is basically the conduit. It acts as a conduit for urine. The urethra just leads the urine out of the body, and for the ejaculation of semen. It has several components in this, and I'm going to take you to a cross-section of the penis. This is a longitudinal section. Here's a cross-section. The human penis has no bone in it, despite teenagers' propensity to talk as if it does. And the reason I mention it is that many lower animals and mammals do have bones to create the stiffness in their penis. The human has a different system. On either side of the shaft of the penis, the main body of this is called the corpora cavernosum. Two of them are called corpora cavernosa, and they are very spongy material. They have lots of little tiny caverns within them, and going through the middle is a deep artery. Now, when the right reflexes are sent to the penis during sexual stimulation, the artery opens up more widely, and the vein, the dorsal vein of the penis, which is shown here at the top, closes down. And so what happens is this spongy material fills up with blood. So erection is a function of the blood engorgement of the penis, mainly in these two bodies. There's also one on the bottom called the corpus spongiosum, which protects the urethra. And it too, the whole thing is covered in the same covering, continuous with the one we saw around the scrotum. Now, what happens is that during erection, arterial flow increases, venous flow decreases, and this is all regulated by the parasympathetic innervation. I don't know why, but it is separate from ejaculation. Ejaculation is sympathetically innervated, so they're both separate. Erection is signaled by sight, sound, touch, and imagination. So it certainly is a higher center of control, but it's all mediated by the parasympathetic system, yet separated from ejaculation. I've asked many experts in both anatomy and evolution as to why this should have been separated this way, why one or the other, and they all shrug their shoulders, and nobody's ever been able to tell me, so I can't tell you. We can guess, but it really wouldn't make any sense. We have a sphincter that closes at the base of the bladder during this process of ejaculation, because what we don't want to happen is any urine to mix with the ejaculate. It doesn't have the right pH and it doesn't have the right chemistry. So the prostate provides that muff, and so during erection and ejaculation, it's usually difficult or impossible for any urine to pass by. There are accessory organs there which undergo contractions and allow lubricant and buffers to get in with the sperm and again protect them on their way. It's a sexual reflex that elicits strong muscular contractions so that the sperm are fired out and hopefully will release and reach their target organ, which is the opening to the cervix, as closely as possible. And the distance between the opening in the vagina and the normal length of a penis is exactly that, so that the sperm will be deposited as close as possible to the opening of the cervix. Now, the semen contains the spermatozoa. It contains seminal fluid that we got from the accessory glands. Its volume is about on the average about a teaspoon, 5 cc's. And in that 5 cc's are about 100 million individual sperm. Seminal fluid is bactericidal. What it does once it's out of the male, it will clot. It will form something very much like a blood clot and stay together. And then over a period of about 20 minutes, when the time is right, when most of that clot has bathed the cervix, then it liquefies to allow the sperm to get in there and swim upstream. Only one sperm needed to fertilize the ovum, and again, it's a matter and truly a function of just odd statistics. We have so many because we need the statistics. Let's look at the prostate for a minute before we go on and talk about this organ, which is the cause and source of a huge amount of male pathology. The prostate gets several types of disease. One is called BPH, benign prostatic hypertrophy. The whole prostate, in a benign manner, not malignant, swells up and becomes bigger. But if you look at it, it's in a very tightly contained compartment. It has bone here, rectum behind it, pelvis on both sides, and swelling of it really can't go very far. What it will tend to do is close down the opening to the urethra. So the symptom for these patients is urinary obstruction. This happens in men over the age of 60 generally. It's extremely common, far more common, for example, than prostate cancer. And we see certain symptoms. First of all, the patient is unable to completely empty the bladder. So that patient has frequency. If he has 500 or 600 cc's in the bladder, only urinates 200, then it's going to be a very short time till he's full again, as opposed to the younger person who'll empty all 600 and is making the same amount. So the patient has urinary frequency. He also may get to the point where the bladder's so big that the pressure forces its way out, and that's called overflow incontinence. So the patient may have leaking and urgency because the bladder starts to squeeze. If you look at this picture, you'll see there are lines in the bladder, and those are the muscles underneath the mucosa shown here. And these lines are called trabeculation. Heavy trabeculation is seen in patients who have a bladder that's trying to squeeze all the time. And one of the things we can do for these patients is there is an instrument called a scope, and it has a knife on the end of it, a rotating knife, and it can be passed up through the penis right into the base here. And this is called a transurethral resection of the prostate, and the surgeon can cut across the urethra and taking little bites at a time with this rotating blade can actually remove the whole prostate within its capsule. And the little pieces are flushed out in water and taken out right again through the penis. And you're left with a hollow here. But the urethra will then grow themselves and line this hollow, or it will scar down a little bit, leaving this in continuity. The patient's ejaculatory ducts are here. This patient may actually ejaculate into the bladder. He will still produce semen, but that ejaculation will occur into the bladder. And in cases of cancer, which can also occur in the prostate, one of the big diseases in the male population, aside from using chemicals or radiation, there are ways to get in coming over the top of the pubic bone. This is called a suprapubic or retropubic prostate operation, prostatectomy. And this entire gland can be taken out with its cancer, and the urethra here, so to the urethra there. Usually these patients are left without sexual function because the nerves that supply ejaculation and erection may be injured in taking them out. You can also go between the rectum and the base of the penis, called a perineal approach, and come up from the bottom and do the same thing. So those are the surgical approaches to diseases of the prostate, very common, very debilitating, and now under great controversy as to what is the best treatment. That's our trip through the male reproductive system, and next time we'll look at the female reproductive system.